I'm Bob Anderson. I'm one of the partners here at Titletown Sports Medicine and head up the foot and ankle division of one. So it's good to have you all out, and if you haven't had a chance to see the facility, please, after we're done, walk around and see what a unique environment this is that I'm fortunate enough to work in. Subject tonight, I was asked to talk a little bit about our new weight-bearing CT scan technology that we have here at Titletown. It's something I became very interested in when I was down in my previous job in Charlotte. Had the opportunity to get involved with weight-bearing CT scan down there about 4 or 5 years ago and had a very, very good experience with it, found tremendous benefits for our patient population. And then when I came up here to Titletown, I was able to encourage Bellin to purchase similar technology, and they did a big investigation and then were able to hook up with CARESTREAM, and you'll hear more about their CT scan technology in a minute. But what I thought I'd do is just basically sort of walk you through why we use weight-bearing CT scan, what we believe the advantages are, and encourage you all to think about it. If you have a patient you think could benefit from this technology, please let us know, and it's here waiting for you to use. So what I titled this is Weight-Bearing CT, New Technology to Improve Patient Care, because I really truly believe that it does. It's sort of the advancement we've had that really puts standard CT scan off to the side. Now, as I always say, this is something I got from Bill Hamilton, who's a renowned orthopedic surgeon in New York City. You may not have seen it, but it has seen you. You can go ahead, yeah. Okay, you just hit that. I can just do that one click. So just click it. Is it going? The eye sees what the mind knows. And I say this because when we look at x-rays, it doesn't tell the whole picture. When you look at a lot of our imaging studies we have now, it also doesn't tell the whole picture. You got to think about, okay, what else could be happening, particularly as it relates to instability. And let me see if I can get this. So these are the diagnostic challenges we have with the lower extremity. The foot and ankle itself has very complex anatomy. You're talking about 26, 28, bones, joints, a lot of things, moving parts. The way the mechanics work from the ankle to the toe is very unique, and there's a lot of subtleties that occur, particularly in the joint, ligaments, things the tendons act on, and it's always hard to get an idea exactly what's going on inside that intricate anatomy. Then we talk about the knee, the hip, the leg, the foot axis. What's going on above the foot and how does that influence what we see at the ankle and foot level itself. So you got to think about our access, particularly to the knee, and a lot of us were taught but don't always adhere to the principle that when you see a patient with foot and ankle problems, you need to make sure you're also looking at their knee. What is the alignment at their knee? Are they genuvarum, genuvalgum? So we look at the foot, we say, yes, it's a high arch foot, it's a pes cavus, or it's a very flat foot, pes planus. But also we need to consider what goes on above the knee, as you see there in those pictures there. So we have all those diagnostic challenges, but we also have a lot of people that come in that are post-injury or perhaps post-surgery, and they just haven't done well. So they may have a fracture, and you're looking at your x-rays and wondering, has this really healed? Could this be the source of their pain? They may have a fusion that's been done, and you wonder, is it truly united? And we have studies now that show us the insufficiency, so to say, of what a plain radiograph has in regard to assessing fusion. That now people have said that the CT scan is probably the gold standard to assess whether or not you have a fusion. And again, it's something that we've been looking at for many years. What about residual deformity? We get people who come back that had surgery, everything looks great, then 3, 4, 5 months afterwards, they start to have some changes in their foot, ankle and such, and they got a residual deformity. You question, okay, why did they get this, and where is that deformity coming from? And then we have also patients that come in that have hardware issues. And is the hardware failed? Is the hardware prominent? And a lot of times these are difficult challenges because we can't always recognize exactly what's going on with a typical radiograph. And so for that reason we say, okay, well, let's go to the next imaging level. Let's go to CT scan, let's go to MRI. Because those procedures, those imaging studies have been around for a long time, as I mentioned here, help to define the extent of fractures. They help to look at what's injured from a ligament standpoint. Are there any osteochondral lesions present, particularly in the ankle joint area or even the knee? And areas of subtle diastasis, that separation, that little joint manifestation you may see from a ligament injury that has some instability associated with it. Now, MRI and CT scan, as Oak and others have mentioned, are very sensitive for detecting ligament injuries, but they're not prognostic. So we get these studies, these CT scans, and you get these MRIs, and you see a lot of stuff going on, but yet is that really important or not? It doesn't have any bearing on whether or not we get this player back on Kurt's situation across the street with the Packers. You know, what does that mean? Is this guy, yes, he's got a lot of things on his MRI or CT scan, but is it stable? Can he play? Can he play without risk? Because the issue is that the way standard CT scans and MRIs are done, they're lying in a supine position, they're static studies, they're not dynamic, they're not placed under stress, and so they're not predictive for areas of subtle instability. So that's our real issue using these imaging studies. So what about weight-bearing CT scan? And this has been fascinating since the first time I heard that this was even feasible to do weight-bearing CT scans. Well, what weight-bearing CT scans will do is they'll help to detect subtle abnormalities. So they can draw out ligament instability, areas that are unstable, and then with weight-bearing, you can now see the mild diastasis, the mild subluxation more readily. They're also very helpful in picking up occult fractures. So again, you see these imaging studies. This is this is one of our players here on the bottom. You'll see the weight-bearing CT scan of both ankles, but then we do a coronal view, and you see where that fibula is not reduced within the sulcus of the tibia. So that's a syndesmotic injury that's mal-reduced that is obviously an issue. And that cannot be picked up on a standard radiograph. A lot of times that's not picked up on a standard non-weight-bearing CT scan because you're not stressing that mortise to create that subluxation event through that syndesmotic area. So again, this is why then weight-bearing CT scan is so advantageous. Now again, our unit down in Charlotte was the PEDCAT on the far right side. Now I've had the opportunity to utilize the unit here for almost a year, I guess, right, ladies? Almost 6 months to a year, something like that. And so I've been using the technology for almost 5 years or even greater. And I tell you, this new CARESTREAM unit has been fantastic. It's much more powerful, and I find much more useful than what I had in Charlotte. So the advantages are many, and I'll go through that in just a few minutes. But I do believe there's huge advantages to doing weight-bearing CT scan. So Bellin was very kind and supportive and agreed that a weight-bearing CT scan was a technology that we could utilize here at Titletown and provide the community in the region to assist with evaluation of lower extremity injuries. So this is the CARESTREAM cone beam CT scan. I'm going to ask Dan Bailey, who's with CARESTREAM, to maybe talk a little bit about the terminology here in a few minutes. But what it does, it basically provides more than just weight-bearing evaluation to the foot and ankle. This unit's versatile, much more versatile than the other one out there, the one that I had familiarity with in Charlotte, in that it allows you to go above the knee. So you can actually get images of the knee, but you can also put the patient in a sitting position, and you can evaluate the elbow, wrist, and hand as well. So again, it's very versatile, has outstanding software and many applications. So again, this is the CARESTREAM weight-bearing CT scan that we have right down the hallway here. But again, the patients find it's very comfortable. Michelle and Angela have a significant experience with the one here, and they could comment on this as well. But I don't get any complaints from people. They find it very comfortable. They find it easy to stand on one leg. And we try to accentuate as much weight bearing as we can on that one limb to highlight any areas of instability as mentioned before. So again, this is some of the images that CARESTREAM provides to show that. So this is the CARESTREAM cone beam CT scan. And again, you can look at images from the knee, images from the ankle, as you see, from the elbow, as you see there, a occult fracture of the distal humerus. Radial head injuries, you can pick those up readily with this scan. And then, of course, you have the opportunity not only to look at the foot and ankle inclusively, but also to obtain 3D images of that, which can be very beneficial, again, when you're trying to determine exactly what type of surgery to do, how to approach it, how to get to your pathology, and how to make your way to the area of concern itself for reconstructive purposes. So again, the opportunities to go above the knee, go to the upper extremity, and also have the best of the best as far as technology is concerned for the foot and ankle region. So why do I use this in-office cone beam CT scan? Why was I pushing Bellin so hard to get this? Well, there's a lot of reasons, and I'll walk you through the different reasons as I see them. But I think first and foremost, it allows me to make good clinical decisions in a timely fashion. So I do see a lot of patients from out of town. We see a lot of athletes from out of town. They fly in, And the last thing I want to do is say, well, you need a CT scan, we'll order it, we'll get it back at home, send me the disc, I'll look at it, and then I'll contact you. And that's very difficult to do, and it takes up a lot of time, and it's just not very efficient, and a lot of these people need to have immediate answers. So now having the ability to do a weight-bearing CT scan in our office, not only is it convenient, it's very rapid, and patients love it. Patient satisfaction is very, very high with that. So it doesn't have to just be an out-of-town athlete. It's any patient who doesn't want to see you, drive across town, get a CT scan, then make another appointment to come back and see you again. We can do that all in one-stop shop. It's cost-effective, it's safe, it has low radiation as compared to standard CT scan. High-resolution images. I've been very impressed with the new CT scan that Dan and his group put in as far as our image is concerned. I know when Michelle was first doing a lot of these, it was a little slower, a little less efficient. Angela and I would talk about that doesn't look right. And then they bumped up the software, and we've had an incredible ability to assess bone and joint and even soft tissue injuries around the lower extremity. You can see around metal, they have new software, metal artifact reduction techniques that can be placed into the evaluation process. The ability to do dynamic weight-bearing images, again, the weight-bearing images, looking for postural changes with weight-bearing, cartilage loss with arthritis, and then also allows you for basically healing evaluation, whether it's joint fusion or fracture healing, so all those things. So let me take them one at a time. Patient convenience, same-day service. The vast majority of people, when they're here, I think, okay, you need a weight-bearing CT scan, boom, they get it. One of our technologists is doing it in just a few minutes. The scan itself takes 5 minutes, maybe.
The CT itself takes 25 seconds.
25 seconds.
And there's 2 pictures before, usually 2 pictures before the scan. So, yeah, they're
It's
in there for a couple minutes. Yeah.
It's a couple minutes to do it. So I mean, it's very, very, very quick to do the scan. Then you have to render it, and you have to push it into the PAC system for us to evaluate and review in the patient's room. And that was a little longer. Now you guys are down to 10 minutes, and boom, it's in the room. So it's very quick, and allows me, I can see maybe 1 patient, 2 patients. By the time that patient goes down the hallway, gets a CT scan, comes back, it's rendered, I go back in the room, and we have a decision right there. Classic example today, we had a basketball player come in from out of state. They needed to know whether they could play in the tournament this weekend or not. We did a weight-bearing CT scan. It showed that he was subtly unstable. We show him the picture, show the doctor the picture, the family the picture, and say, no, he's going into cast. He's not playing this weekend. So it's that kind of thing. You can make a decision right away. So same-day decision-making, no driving around, no return appointment necessary. So I think those are tremendous advantages from a patient convenience standpoint. I think also cost-effective. So this unit is much less cost to run than a standard CT scan unit would be in a hospital situation. So some of the studies have been done. One of my former partners in Charlotte, Brian Curtin, actually wrote a white paper for CARESTREAM, and they looked at all the finances associated with it. John Gleason down in Atlanta with Resurgence Group did it as well. And so the cost is approximately 25 to 35 cents less than you would have with a standard multi-slice CT scan in a hospital setting. So again, cost effectiveness is important. And I think too, radiation dose. We don't always consider how much radiation is imparted by a standard CT scan unit. The radiation dose, due to the design and the shielding that it has incorporated into it, the radiation dose to the patient is approximately 4 times lower than a standard CT scan unit would be. So again, I think these are very important situations for the patient, and again, benefits to not only us, but to the patient as well. I think probably the most intriguing opportunity of the weight-bearing CT scan is for dynamic assessment. This is the whole idea of weight bearing. And you can use this unit as a non-weight bearing device, but by weight bearing, placing the extremity under natural loads or accentuating them with a true one-legged standing as pain allows, you can get a better idea of what might be lax from a ligamentous injury standpoint, arthritis, how much loss of cartilage you actually have had. So again, you can have a joint that doesn't look that bad on non-weight bearing. You ask the patient to weight bear, and that joint comes down bone on bone and sort of accentuates or identifies the loss of cartilage space. But it also defines where your deformity and location is. So I get people who come in that have these horrible cavo-varus type deformities. They're walking on the outside of the foot, and it's hard to know whether it's their hind foot that's in varus, is it their ankle in varus. They may have had a previous calcaneal osteotomy. We're trying to figure out, did that osteotomy, was it successful? Did it actually realign them or not realign them? When you get somebody to weight bear and you get an axial CT scan, as you see on the far right, that gives you a great idea exactly what's not in proper position. So again, that's just an example on the far right where you see a patient that has severe valgus of their ankle, their hind foot. And this is a person that actually had a lot of pain in between the distal fibula and the calcaneus. So you can see why they developed significant amount of lateral gutter arthritic changes at that level. So again, this is the kind of opportunity you get. This just is an example here on the left of what a foot might look like non-weight bearing and then weight bearing. And you see that here, the abutment, this person has subfibular pain, pain in the area of the distal fibula right around the sinus tarsi. Non-weight bearing CT scan, it looks like they have a pretty good calcaneal pitch, calcaneocuboid joint, subtalar joint, and that so-called angle Gasson there looks pretty open, looks pretty wide. Then you let them weight bear and you see how they have instability of their hindfoot joints, they sublux, now they're driving their lateral talar process into that calcaneus, and this is obviously the reason they're pain. You can see now they don't have a good calcaneal pitch. And so again, all highlighted by just weight bearing these particular patients. This is another example down here, again, highlighting this. We've gotten several of these now where you get people that may have some underlying neuropathy, some Charcot changes. They look pretty good when they're non-weight bearing, but then you weight bear them and you can see the amount of subluxation, the amount of instability through the hindfoot or ankle that then creates these abutment areas. And then if you get an MRI, you'll see all the inflammation in that area as well. So again, highlighted by the weight bearing. Similarly, this is an example of a coronal CT scan, non-weight bearing and then weight bearing. And again, look at this space here and look what happens when they weight bear on it. So it's no wonder these people have a lot of pain just because of that bone-on-bone contact that's generated by weight bearing, which otherwise would not have been appreciated by a static non-weight bearing study. So again, dynamic assessment I think is outstanding. The other area I've been using it quite a bit is we'll get some athletes, some runners in that have metatarsals or sesamoiditis. They may have had a previous metatarsal osteotomy and they come in with transfer metatarsal type pain. And you go, well, what's going on in that forefoot region? And I found that this particular study is fantastic for forefoot abnormalities. So you get them to weight bear in the gantry, so to say, and I can see what's going on with the sesamoids. Are they sublux? Are there arthritic changes here? If they've had a previous metatarsal procedure like this person did, you'll see the third is a little bit elevated, the second is a little bit down. They have pain right in that area. This is a great way to see if there's bony prominences, if there's asymmetries on the bottom of the foot that may account for some of the pain. So again, if we get an athlete that sesamoids are well reduced, but he's got pain under the tibial sesamoid, it's a great way to look to see if his tibial sesamoid is more plantarly positioned than the other metatarsal heads and the fibular sesamoid are. So again, I've had particularly great success utilizing this unit for the forefoot issues, bunions, sesamoids, and metatarsals, as I show there. So here's an example. This is interesting. I talked about the one we had today that had an unusual midfoot injury. And the question is he stable or not stable? And we found that weight-bearing CT scan, he had some joint subluxation of his first tarsometatarsal joint. This was a kid from Oklahoma who actually was injured in one of the last regular season games this year, was supposed to play in the bowl game, tried to play, it's actually a playoff game for the college tournament, and just couldn't go. Something was not right. They all said, oh, he got a midfoot sprain, everything looks great, not an issue. It's his left foot that hurts. You look at the relationship, and everybody said that x-ray looks fine. We went ahead and put him on the weight-bearing CT scan, and what you'll find is he actually has one of these proximal or medial column Lisfranc variants where this was grossly unstable, and you can see that he's subluxing his cuneiform on the navicular itself. And again, we had this image under weight-bearing. We could see exactly what was going on, and sure enough, that's where the site of his concern was. We can also do these 3D reconstructions, which very nicely then showed that, yes, we've got an unstable first ray with an injury through the intercuneiform joint and out that navicular cuneiform joint. So again, it's just a way to highlight these injuries, and this young man unfortunately had to stay another day, and we had to fix him, and hopefully he'll recover well and play at the next level. But again, this was a fantastic study for this particular situation where you had a guy that everybody thought was a stable midfoot injury, and sure enough, based on his weight-bearing CT scan, was not stable. He had subluxation. That's a dynamic assessment. It's still a great unit for fracture evaluation. So you can evaluate all kinds of fractures. And you can do that, again, non-weight bearing or weight bearing. This is, I think, it's obviously I get CT scans in all calcaneus fractures, but you can evaluate the extent of the fracture, particularly the calcaneus or any fracture really of the lower extremity, knee and below. It just gives you the opportunity to look inside what's actually happening, which a plain radiograph just can't do. What I mentioned before is that this unit, particularly the new software, is great for evaluating the extent of trabecular bone bridging when you're looking at how far has this fracture healed. So we need to know whether fracture is healed or not healed to be able to tell our rehab specialists, our physical therapists, our trainers how aggressive to be. So again, with the evaluation of a fracture, looking at healing, looking at trabecular bone bridging, it gives you greater confidence in how to recommend progression of weight bearing in our patients with lower extremity injuries. So again, you can do this with the metal artifact reduction software that improves visualization. So you can see same patient, but you're just subtracting out the metal, gives you a lot better opportunity than to see the fracture healing itself. That's of the tibia plateau. Here's a person with a pilon fracture of the distal tibia. And again, by subtracting out that metal, you can get a much better idea of not only trabecular bridging and how their fracture is healing, but what is the true contour of their articular surface. Have we done a good job reconstructing that? Do they have defects and such? So again, years past, our standard CT scans would give you so much scatter, you couldn't do that kind of evaluation. With this particular CT scan, not only its technique and its original software, but adding this metal reduction software package really helps to be able to assess that much better. And then you can also flip it, and you guys have been doing this, I think, pretty much almost in every patient, is we get a soft tissue unit and we get the bone unit, a soft tissue window and a bone window. So you look at all the bony issues and well with the CT scan, but then they can flip it to another technique and then get better definition of the soft tissues. So again, you can look at your Achilles tendon, you can look at your peroneal tendons, utilizing the CT scan with this soft tissue window. So again, things that you can do, things you can highlight with this new unit and the technology available. And this is now where I'm really fascinated by it, because as I mentioned earlier, we now know that doing an X-ray on a patient that's undergone a fusion may overestimate the amount of union, the amount of healing that's actually there. And Mike Coughlin, one of my good friends, did a paper several years ago saying that if you really want to assess a subtalar fusion, a triple arthrodesis, as far as how much union has occurred, you really have to get a CT scan. And this is where I'm using it quite a bit in our office. I pretty much at 3-4 months post-op have everybody get a CT scan who's had a fusion, so that I know that they're fully fused and I can actually advance their weight bearing opportunities, their rehab opportunities. So I truly believe that getting the CT scan is the new gold standard, and it makes it very easy when I have the unit right here in the office. I can see them, send them down the hallway, and get my answer right away. We had a lady today, she's 9.5 weeks out from an ankle fusion. She's not compliant. She's insistent she comes out of her boot. So we do the CT scan today. It shows that she's got complete union. So I said, okay, you know, you're fortunate. You got complete union. We'll go ahead and let you get into a shoe, advance your weight bearing activity. So this is a young lady that I inherited here in the area who had had multiple surgeries in the past. Ankle fusion was successful. Then they tried to fuse her subtalar joint. Had ongoing pain. This was her radiograph. This was her initial CT scan that we did here last fall. And then you can see she's got a persistent non-union of her subtalar joint. We went in there, we took out a lot of her metal, refused the subtalar joint, a couple screws, and now at 11 weeks post-op, she's united. So again, a great way to utilize the unit to assess for fusion analysis and weight bearing recommendations. So I think just in summary, the weight bearing CT scan for me has numerous advantages. It's almost now like a why not type of, you know, almost knee-jerk response is, you know, we want to get a CT scan. Why wouldn't you do it under weight bearing circumstances to highlight various areas of instability, look at postural changes, and help to make rehab decisions. So I really think that now we've got this. It's available to all physicians, practitioners, and patients in the region. And we just want to get the word out and let you all know it's here, ready to go. Got a great staff that's running it, and the results thus far have been outstanding. So with that, just let us know how we can help. If you need any patients that need this, just give us a holler. We're happy to get them in. Easy access, like I mentioned, and happy to take any questions.